I'm Dr. Paul Cagle, and this is my advanced course on subscapularis repair with shoulder arthroplasty. In Chapter 1, we're going to discuss the preoperative aspects of shoulder arthroplasty and subscapularis repair. In particular, we'll briefly talk about some of the controversies about being able to repair the subscapularis, particularly in a more anatomic style repair, as well as in a reverse shoulder arthroplasty style repair, and some of the positives and negatives of that. Subscapularis management with both anatomic style arthroplasty as well as reverse total shoulder arthroplasty remains a controversial topic. Among the controversial topics is the ability to actually mobilize the subscapularis tendon. One of my preferences is to evaluate the patient images ahead of time and try to understand whether there's going to be some difficulty involved in the exposure or the retraction. In those individuals where you're worried about the exposure or the retraction, having a lesser tuberosity osteotomy offers you that opportunity to potentially remove a little bit of that anterior humeral bone, allowing for slight increase in the posterior translation of the humeral head and more clearance for your instruments. In individuals where you may not have those same concerns, a peel type procedure, as we will demonstrate later in this video, has had good data, and thus lesser tuberosity osteotomies as well as subscapularis peel techniques can both be employed with the expectation that the subscapularis would be able to go on to heal. One of the other primary concerns is discussing the ability to reposition the subscapularis both in an anatomic style arthroplasty as well as in reverse style arthroplasty. This can be a concern that can often be addressed by doing something like a subscapularis peel. By utilizing that technique, occasionally the tendon can be repositioned more anatomically without having to have the concerns about the bony opposition or an anatomic recreation of the lesser tuberosity osteotomy. Although with the utilization of the technique we're going to describe, placement of the lesser tuberosity osteotomy in anatomic position becomes slightly easier because of the ability to position the drill tunnels and sutures around this bone directly. The final concern with mobilizing the subscapularis is the ability to actually be reduced if there's a partial tear or perhaps even a complete tear. I believe this needs to be properly evaluated in every case and as a surgeon by surgeon, case by case discussion where best judgment will need to be utilized to understand the overall integrity of the subscapularis and whether this can be repositioned to the lesser tuberosity in a way that would be adequate for its fixation as well as would not impede the overall function of the anatomic or reverse arthroplasty. When considering a subscapularis repair in a reverse total shoulder arthroplasty procedure, one has to understand the mobilization of the tendon. Intraoperatively, each surgeon should evaluate the ability for this tendon to be mobilized, and this is after it's been appropriately released, as we'll demonstrate later in our video. If it is able to be appropriately released and it does demonstrate the ability to translate to the lesser tuberosity, this can be repaired routinely in reverse shoulder arthroplasty positions, although the data for this is still conflicting. So why do we care? We care because one of the early failure points of a total shoulder arthroplasty is the subscapularis. And we all want our patients to do well, which involves early mobilization. And thus, understanding the mechanics of the subscapularis and getting an adequate fixation for early mobilization is critical. One of my personal biases is to repair the subscapularis. Although this is still controversial in the literature, I do believe that a well-mobilized subscapularis that's repaired in an anatomic construct offers you not only the ability to restore that mechanical advantage, but also offers you a potential restraint to dislocation. As instability is a common complication after shoulder arthroplasty, this provides me with a little increased sense of reassurance for my patients.